for our closer, we have Aida Moafi, the University of Leicester in the United Kingdom. Let's hear it.
So good morning, everyone. I'm Aida from University of Leicester. I'm a clinician by background and a third-year PhD student in multidisciplinary subject. I'd like to thank Mirkes for organizer for this opportunity to present our work today. I'll be talking about robust deep learning for myocardial scar segmentation in cardiac MRI with noisy labels, a collaboration with colleagues from Leicester, Siena, and Copenhagen. In this talk, I briefly cover why accurate scar segmentation matters, the challenges, and how we solve this. So cardiovascular disease is the leading cause of death worldwide, responsible for nearly 1 in each 3 deaths. A major contributor to this burden is myocardial infarction or heart attack. And for those that survive, the heart is often left with a permanent scar tissue. And this is the problem we will focus on. But why scar quantification matters? Even a small increase in a scar size, just 5%, raises the risk of death by almost 20%. It also guides decision about ICD implementation, which can be life-saving for patients at the risk of sudden cardiac death. Scar tissue also disrupts the heart's electrical pathway, triggering arrhythmia, and it's strongly linked to heart failure hospitalization and drives progressive cardiac remodeling. So this 5-dimension highlights that scar segmentation is not just a technical problem. It directly informs prognosis, treatment, and long-term patient outcome. But scar segmentation does come with challenges, whether done manually or with deep learning. First, the images itself is heterogeneous. Different scanners, vendors, sequence, and protocols produce a strong variability in appearance, which makes generalization difficult. Second, the scars are often very small and fragmented, representing only a tiny fraction of the myocardium. This creates a severe class imbalance. Third, the annotations are noisy. Scar borders are hard to define consistently, even among experts. And even semi-automated methods, like full width of maximum, still introduces a structured uncertainty around boundaries. And finally, manual segmentation is slow and impractical for clinical use, which can take up to 25 minutes per patient. And that's why in clinical setting, they still rely on qualitative assessment. So these are the challenges that we are going to solve. This is our pipeline designed to solve this. It's quite straightforward. It's a fully automated system that integrates detection, segmentation, and robust training. First, we use the latest version of the YOLO model to detect the scar and draw a bounding box around it. Next, the box are passed as a prompt to the segment anything model, which generates the scar segmentation. And finally, to make the model more robust, we train it using a composite loss that combines overlap and distribution-based term, which I will explain in upcoming slides. Here is our data set, 348 patients and 2,840 images collected across multiple centers, giving us both scale and diversity. On the left, there is a TSNE plot, where each point represents an image colored by cohort. The spread shows large variability in factors like scanners, protocol, and patient population. This heterogeneity makes scar segmentation, of course, more challenging, but it also ensures that our evaluation reflects real-world clinical condition. So I mentioned that our labels are noisy, specifically a structural noise out the boundaries. Because the semi-automated used a fixed threshold, it produces binary masks with sharp edge, which don't match the real anatomy where scar transition are gradual. To address this, we created soft labels by smoothing the mask with a Gaussian filter. The sigma was carefully tuned as a hyperparameter, given high confidence at the scar center and gradually lower confidence near the edge. So with soft label, we also need to adopt our loss function. We keep the standard DICE and BCA term for segmentation, but add Kullback-Leber term, which uses the soft labels to model boundary uncertainty. This makes training more stable and robust for noisy annotation. Before I present our result, I just want to quickly touch on our evaluation metric. We all report DICE. It's a standard segmentation metric. But in medical images with tiny structures like myocardial scar, DICE can exaggerate small differences. Here, 1 missed pixel caused DICE to plummet from 0.8 to 0.5, even though the predictions are quite close. DICE only measures overlap, and in this case, the shape and size are perfect, just slightly shifted, yet DICE drop to 0.5, implying failure. This is why we include Hausdorff distance, area of similarity, and perimeter of similarity to give a fuller picture of segmentation quality, especially for our clinical use. Before building the fully automated pipeline, we first tested the idea of localization. We compared NN unit, a strong baseline, with two models that received ground truth bounding box, SAM and modified DeepLab V3+. Adding these prompts clearly improved the segmentation across all metrics. Between those two, SAM performed slightly better, so we adopted it as the backbone for our automated pipeline. Here is our report, the quantitative of performance of our fully automated YOLO-SAM pipeline across the 8 cohorts. Each cohort is shown separately, and each color corresponds to one of our evaluation metrics. What I want to emphasize here is the consistency. Despite the variation in scanners, centers, and acquisition protocols, the performance trends is quite stable. This is important because it shows robustness in heterogeneous real-world data. And in terms of absolute values, the mean DICE is around 0.6, while area of similarity and perimeter of similarity are close to 0.8. This cap is expected given the noisy ground truth labels, which I'll show into the next slide. In the first row, DICE score is only 0.15, which looks terrible, but the model actually captured the score region very well. The area of similarity is 0.85, showing that the size of the prediction is close to the ground truth. The low DICE mainly comes from a slight spatial offset in the ground truth annotation. In the second row, we see the same pattern. DICE is moderate, 0.52, but area of similarity is almost perfect. The prediction is clinically acceptable, even if the overlap metrics suggest otherwise. So these are the examples to show that the importance of evaluating SCAR with multiple complementary metrics. Finally, to see how well our model generalized beyond its training domain, we tested on 400 acute cases. The model was trained on chronic cases only. From the predicted segmentation, we extracted simple morphological descriptors and used them to distinguish acute from chronic cases. The plot shows that features like scar size and compactness carry useful clinical signals, showing that our model captures meaningful morphology, even outside its training domain. So to conclude, here's the key comparison. On the left, our fully automated YOLO-SAM pipeline. It's fast, requires no manual input, and performs robustly across noisy heterogeneous data. And on the right, it's the traditional current assessment in clinical setting, slow, observer-dependent, and less reproducible. And in terms of our future work, we've already built a GUI backed by these two models, allowing clinicians to step in and refine prompt or add more point prompts for segmentation, especially in challenging cases. And now we are testing reproducibility and validation, comparing the scar mass derived from GUI with other established cardiac MRI measures between different experts. And finally, we plan to close the loop with an active pipeline to see where the model is failing and sample most informative cases for labeling. Thank you for your attention. The code and paper, you can use the QR code. And I want to thank my supervisors, Prof. Gerry McCann, Dr. Ranjit Arnold, and especially Dr. Mostafa Mehdipour Ghazi. Thank you.